right, everyone, we'll make a start. I know you can't see me. My name's Marian Dover. I'm chairing this amazing panel group tonight, and I thought we'd make a start because we've got lots of amazing things to cover and some very important panelists online that I'd love to hear from, and I'm sure everyone else here would too. So I want to start with an acknowledgement of country. I want to acknowledge the traditional custodians of land on which we meet tonight across Australia. I have the immense privilege of being on Mirrawong country in remote northern Western Australia. That's probably why my internet is struggling. It is 45 degrees up here. I want to acknowledge their resilience, their courage, and acknowledge that we are on land that was never ceded, that is Aboriginal land. I also want to pay my respects to their elders past and present and extend my acknowledgement and respects to any Aboriginal and Torres Strait Islander people who are with us this evening. So as a bit of an introduction, I started a charity earlier this year known as the Australian Rural Maternity Association. It was founded in late January this year, and this webinar was brought together by the board directors, a very diverse and passionate team of doctors, midwives and consumer advocates whom I'm really inspired by. The non-for-profit that we've built has come together on the reality that rural birthing must remain at the forefront of our priorities as a nation. Rural maternity care affects all of us and it affects the viability of rural communities. We are hoping to build a bit of a scholarship in both midwifery and medicine that will create a pipeline of mentoring and support from university right through to full qualification and beyond. The issues that surround rural birthing are multifaceted and very complex, but at the heart of it are our rural families and our rural communities, and we have to remember that. So I invite everyone to sit back and listen to this conversation amongst colleagues and friends as we explore some of the issues. Audience members, please feel free to participate in the chat. I have some helpers in the crowd. I want to acknowledge the very hard work of Karina Brown and Tina Downton, as well as the rest of our board directors from ACRRM. They are my helpers tonight, and they'll be keeping an eye on the chat. Any questions that we don't have time to cover tonight, we will hopefully send to our panelists to discuss in the future, and we can send you out some responses. Although throughout the discussions we will be referring to women, I want everyone to know that this is inclusive of all birthing parents and families, regardless of their gender identification. There are going to be 3 simple rules. I'm calling this a bit of a game, but 3 simple rules for our panelists. I think it's really important that we remember that we all come from very diverse perspectives and diverse backgrounds and experiences, and this is something I think we should be celebrating and respecting. It's important that we explore the different approaches to a problem. So I know that you guys are all going to remain very professional. No one is here to represent a particular organisation. I know Professor Jenny May has to represent the Department of Health as the National Rural Health Commissioner, but please don't feel that any of this is going to impact on the organisation or multiple organisations that you are part of. And I know that actually I feel like we probably will solve most of the world's problems in 1 hour, but time is going to be very critical, and a lot of the answers are here in this very amazing group amongst us. I ask that, if possible, try and keep your answers really to the point and concise so that we can get through as much as possible. And please endeavour to be focused on solutions. We know the issues. I feel like we've been talking about the issues for decades, but focusing on solutions so that we can forge a pathway forward will be really important. So without further ado, to introduce our panellists tonight, Professor Jenny May, I'm going to start with you. She is our National Rural Health Commissioner. She's a leading voice in rural, regional and remote healthcare. Professor Jenny May is a GP with more than 35 years experience. She's worked across rural Australia as well as internationally. She pairs deep clinical insight with a lifelong commitment to workforce reform and equitable access to care. Professor May is Director of the University of Newcastle Department of Rural Health, and she was the inaugural Betty Josephine Fife Chair in Rural Health. Her work spans across medical education, multidisciplinary training, and research focused on rural workforce distribution and models of care. She was a former chair of the National Rural Health Alliance and has contributed to major national reforms, including co-chairing the review that shaped Australia's national medical workforce strategy. She was recognised as a member of the Order of Australia for her service to community health. Professor May continues to champion the grow, train, retain approach to building a sustainable rural health workforce. In her role as Commissioner, she provides independent advice to government and advocates for strong community-centred health systems across rural and remote Australia. So welcome, Professor Jenny May.
Thank you. Just one slight clarification. I had to resign from the Department of Rural Health when I took on the Health Commissioner's job. So that is being ably run by others.
You are incredible. I will move on to Professor Catherine Chamberlain. So Professor Catherine Chamberlain is a Palawa woman of, I'm going to mispronounce this, from a clan in Tasmania. She's a registered midwife and public health researcher with over 25 years of experience in clinical practice, academia, policy and community-led health initiatives. In her role as Chief Midwifery Officer at CATSINaM, she provides expert leadership to elevate the visibility, voice and influence of Aboriginal and Torres Strait Islander midwives and maternity care nationally. At the University of Melbourne, she leads the Indigenous Health Equity Unit within the School of Population and Global Health, where she advises on strategic perinatal workforce development, education, and culturally safe maternity services. Professor Chamberlain is Principal Investigator of two major multidisciplinary research programs, Healing the Past by Nurturing the Future and Replanting the Birthing Trees. She's also the inaugural Editor-in-Chief of First Nations Health and Wellbeing, which is a journal and has been honoured with awards such as the Lewitja Research Leadership Award in 2019 and CATSINaM Fellowship in 2022 in recognition of her outstanding contribution to Indigenous maternal and child health. Professor Chamberlain's work is grounded in culturally safe, trauma-informed and healing-centred approaches, and she is deeply committed to mentoring the next generation of Aboriginal and Torres Strait Islander midwifery and health leadership. What an intro. Welcome, Professor Chamberlain.
Thanks. Sorry about that. Clearly someone else wrote it for me. It's a bit too long. Sorry.
Guilty. No, that's fantastic. It's so good to have you. Thank you. Dr. John Hall, I'm going to move on to yourself next. Dr. John Hall is the Western Director of Medical Services for the Torres and Cape Hospital and Health Service based at Weipa. A highly experienced rural generalist and GP obstetrician and a mentor of mine, he has dedicated his career to strengthening maternity care in remote Australia, including leading the revival of birthing services in Weipa after a 25-year hiatus. Dr. Hall is also a past president of the Rural Doctors Association of Australia, serving from 2019 to 2021. He has long been a vocal advocate for rural maternity services, helping shape policy and training programs to ensure women in remote communities have access to safe local care. In addition to his leadership role, he contributes to medical education, particularly by facilitating rural emergency obstetrics training, and remains committed to building the next generation of rural clinicians. He's highly involved in the College of Rural and Remote Medicine. Welcome, Dr. John Hall.
Great to be here, Marian. Thanks so much for putting this on. It's a really great forum.
Absolutely. Thank you for being part of it. Cristina Miskin. Cristina is a passionate community advocate for rural maternity services. She founded the Save Camperdown Maternity Petition in response to the suspension of birthing services at Camperdown Hospital, mobilising local families and health stakeholders. Through this campaign, she rallied community support. As of August 2024, over 2,500 people had signed the petition that she started. Her activism has put local and regional maternity issues in the spotlight, helping to mobilise political and media attention. If that's not enough, Cristina is also a mother, and she's a registered nurse and midwife in the Camperdown region. Cristina utilised her frontline health expertise and community leadership to amplify the voices of expectant mothers in regional Victoria, emphasising continuity of care, equity and access to local maternity health support. Welcome, Cristina. It's great to have you.
Thank you very much, Marian. Thank you for having me.
So good to have you. Sarah Lipscombe, I haven't heard your voice yet. Are you online?
Yes, I am.
Amazing. So Sarah lives in the Macleay Valley on the beautiful mid-north coast of New South Wales, where I once also lived. We've shared many rage and passionate exchanges. She's a busy mother of 2 young children and a teacher. Sarah has a passion for women's health and social equity, and she strives to engage positively with stakeholders and individuals to enhance the well-being of the wider community. Sarah has been a formidable voice in the efforts to maintain Level 3 maternity service provision in Kempsey, meeting with Chief Executive and Members of Parliament to amplify the voices of local women. Sarah, you inspire me, and I'm so happy that you've joined us tonight. Thank you.
Thank you for having me. It's a real privilege to be able to be a voice for the rural women who we need to wholeheartedly advocate for. So thank you for putting on this forum.
Absolutely. It's here for your voice and the voice of all birthing people. So thank you so much. Dr. Nisha Khot, hopefully we've overcome the tech issues and you've been able to join us. Are you online?
Yes, I am. Thanks, Marian.
Amazing. So Dr. Nisha Khot is a distinguished consultant obstetrician and gynaecologist, the president of the Royal Australian and New Zealand College of Obstetricians and Gynaecologists. She currently serves as the clinical director of obstetrics and gynaecology at Peninsula Health in Victoria. Originally trained in India and the UK, Dr. Khot came to Australia in 2010 as a specialist international medical graduate. She's deeply committed to medical education and equity. She is an examiner for RANZCOG's fellowship and advanced diploma examinations. She chairs the examinations and assessment committee and has a strong interest in SIM-based training, particularly in rural and low resource settings. Dr. Khot is a passionate advocate for for diversity in healthcare leadership and champions access to sexual and reproductive care, especially for migrant, refugee and culturally diverse communities. She also serves as board chair of the Multicultural Centre for Women's Health. As president of RANZCOG, serving from October 2025, congratulations, she aims to strengthen the college's role in shaping future women's health specialists, fostering collegial collaboration and safeguarding women's reproductive rights, including access to contraception and abortion care. Thank you so much for joining us, Dr. Nisha, and persisting beyond.
Marian.
Amazing. Last but not least, Dr. Rod Martin. Dr. Martin currently serves as president of the Australian College of Rural and Remote Medicine, or ACRRRM, having commenced his term in October 2024. Based in Armidale, New South Wales, Dr. Martin has practiced as a rural generalist for nearly 2 decades. His medical journey began after a career as a research scientist. He studied at the University of Queensland and followed an RVTS registrar path in Theodore, Queensland, before completing the advanced training in anaesthetics as well as obstetrics in Armidale. He's an experienced clinician and educator. Dr. Martin is a senior lecturer in rural medicine and critical care at the University of New England School of Rural Medicine. He continues to contribute in multiple clinical capacities, serving as a VMO in anaesthetics, obstetrics and emergency medicine. He has a long history of service within ACRRRM, including roles on committees as an examiner for over 15 years and as New South Wales representatives on ACRRRM Council for roughly a decade under multiple presidents. Outside of his professional life, Dr. Martin is also a father of 3 adult children. He oversees his own beehives and he's an enthusiastic open water swimmer, having completed an ice mile in 2022. I thought that was really relevant to add. Welcome, Dr. Martin.
Thank you. Yeah, the I Smile thing's just a bit crazy. I was lectured over the weekend by someone about it.
You're amazing. We might touch on that later. So we're going to get stuck into the questions straight away, if that's all right, because I want to pick your brains, and I honestly believe we have all of the answers, and we are going to save the world tonight. Sarah Lipscombe, I'm going to start with you, if that's all right.
Yeah.
So from a consumer perspective, would you say, what would you say are the priorities for rural women and families, and what they should have access to?
I think for rural women and families, the biggest priority really just comes down to safety, choice, and continuity. The things that women in cities often really don't have to give a second thought to from the minute they fall pregnant through to their pregnancy care and then to their labour and postpartum care. There's lots of priorities we could address, but the ones that come to the forefront for rural women and families really are for us to have access to continuity of care with known providers. We know that this is the gold standard of care, and the evidence shows that it can reduce trauma, improve outcomes, develop stronger partnerships between women and care providers. But for many rural women, their care is fragmented from the beginning, and therefore we're not accessing that gold standard of care that we promote wholeheartedly within the health system. Many rural women need care that is culturally safe and inclusive, especially vital for our First Nations women, many of whom are birthing up country due to reductions of services or closures within their communities. This is especially important as well for migrant families, young families, and people who are facing socioeconomic disadvantage. We need safe and sustainable local pregnancy and birthing options. Women really just want clarity in rural areas. We want to know, can I give birth safely in my community? And if I can't, why can't I? And when if units are downgraded, bypassed or closed, we need rural replacement pathways, not just the notion of drive to the nearest hospital, which is what many rural women are told to do. And for some, it's not just 30 minutes down the road, it's hours of travel. We need transparency and communication. We need communication about what services exist in our rural areas, what's changed, what is changing, and what safeguards are in place for when the capacity of our unit is limited. I think ultimately rural families, we really just want what all families want, which is pregnancy and birthing and postpartum care that's safe, respectful, and available when we need it, without geography determining our birthing outcomes.
So well said, Sarah. And you've touched on some really important themes and really important issues there. Have you noticed that there's any misalignments between what consumers or patients perceive as the issue and what administrators or political bodies prioritise?
Yeah, I think that there is definitely a noticeable difference with what perhaps the public is receiving and what's being spoken about behind closed doors. I've spoken with women across the country who really report that information and service availability is just often poorly timed, the communication around it, the communication is inconsistent, and the lack of messaging is leading to confusion within rural communities. When I speak with midwives and clinicians across many rural settings across the country, it's evident that there really is a huge breakdown of communication between the decision makers and the staff, which really is having such a huge impact on the well-being of staff members. And it's evident from my own personal experiences and from the experiences that others are reporting to me that it's clear that staff members really are doing their best to provide the best quality care and the best communication they can under really extremely difficult circumstances. But it's evident that the decision-making is not multi-layered. It's the system telling us what exists rather than listening to what women need. And the unknown and the unexpected and continual changes are contributing to women feeling unsafe and quite disrespected.
Absolutely, and such a strong voice for rural maternity, Sarah. Thank you for that. I think that summarises the issues really well. I want to move on to Cristina for a second. What issues do you see can arise in the political and administrative, temptation to centralise services to regional centres?
Thank you, Marian. I think the main concern with that came up in our area, which I assume would be across the country, is the need to travel a great distance to get to another service, and that brings with it a lot of challenges and concerns. The main one being women at risk of birthing on the roadside or at home unplanned. And in rural areas, it takes a lot longer to get an ambulance to assist as well. And because of that anxiety as well, a lot of women would be relocating earlier to larger hospitals to be nearer, and that comes with accommodation costs, being separated from family and other children, and just creating a lot of stress and anxiety around a time which should be special and easeful. And I guess it also could increase the chances of women having inductions of labour as well, to then avoid staying a week or two before their labour starts. So yeah, it's just a whole nother thing that women are having to worry about now.
So true.
Yeah, sorry.
No, please continue.
Yeah, just one more point. We also believe that there would be poorer postnatal outcomes for these rural women. They, being in a smaller service, they often have the option for longer postnatal stays or increased DOM visits and things. Whereas if they go to a larger, busier hospital with large ratios and things, they're not getting the care they need. Once they return home, you know, they're often returning to busy farms and things and limited social support. So being in a smaller service really benefits these women. Rural women have a unique situation that rural hospitals can cater to.
Yeah, absolutely. Thank you, Cristina. I want to ask you the same question that I put to Sarah. Have you noticed that there's any misalignments between what consumers or patients perceive as the issues and what administrators and political bodies prioritise?
Yeah, I think Sarah answered that really well. The consumers in our area have a similar view, I believe. It seems that staffing issues is what's portrayed to them to be the main reason why services would be under threat, and also the desire for larger services to amalgamate so that they can control the operation or consolidate and have consistency between the operation of different facilities. And I guess from a political view, it comes across that they want to amalgamate and have consistency among services, and they have issues with staff retention as well, but they do avoid talking about the funding. We don't really get to the bottom of it, what the real reason is, but the community is definitely under the impression that it's because they want to amalgamate and potentially staffing issues, which hopefully we could fix.
Yeah, I agree. I think it'll be interesting to see if you know, once we get more conversations happening, whether, you know, we actually have lots of shared goals around safety and making sure that there is access that improves some of our outcomes, which also reduces expenditure in health. Rod Martin, I might move on to you for the next one if that's all right. We know that rural birthing affects entire communities. It's an essential part of town infrastructure, I believe. Without rural birthing, young professionals and families are less likely to feel confident moving to a rural town. And when you allow rural maternity to fall over, it has a domino effect on the health service. Staff de-skill, we are less likely to be able to feel confident resuscitating young babies, we lose our anaesthetics, we lose our operating theatre capabilities, and the service downgrades. So it's got a really profound impact on a lot of things and affects all of us. Do you feel that our rural maternity units are supported and encouraged to remain viable?
We're kind of the canary in the mine, except the mine is the labour ward. Look, I over the last kind of year or two, I guess I feel that, and I'm in New South Wales, everyone else is moving to the other states, and I feel like we're kind of in survival mode at the moment. Scrambling is what's keeping us viable. You know, women and babies and their families and the people who look after them being kept safe, often out of goodwill. And sometimes just damn good luck that the right person still happens to be in town at the right time. We've got, you know, some of my midwife mates who've been trying to retire for 4 or 5 years are not doing a very good job of it. And even my boss here, for example, it took him 3 to 4 years to retire. Often it means that that these people are having to triage their own lives to be able to keep everyone else safe. There's enough to keep a unit staffed and open, but not much more. And often we have to stay open because outlying units are having to close and fold into our service, so that it's almost becoming a de facto regionalised service. The sad thing is, I still remember sitting in Tamworth Airport on a meeting, Jenny, one time, telling the state, in this case, that we had this looming issue, this looming peril of not enough people coming in, and the ones who were interested weren't going to have anyone there to supervise them and guide them through and give them the confidence to be able to become good, safe, independent practitioners. And like all places, I'm not telling you anything new. The dependence on locums. A few years ago, it was the dependence on locums, and having that fall over meant that one of us was covering 3 things all at the same time. This year, we will struggle to have enough midwives, I guess. And again, that's a state government imperative to have someone in the building, but when there's no one else coming, the challenge is that you can't conjure them out of nothing, and you're forcing people to do some really dangerous hours, and no real options to transfer because everywhere else is full as a gug and understaffed. And I guess, and probably Jenny and I, for example, have sat around and lots of the people on this call, in fact, have sat around talking about what do we do? How do we rebuild and reimagine how maternity care can be delivered across rural and remote? As you say, Metropolitan doesn't have to think about it quite so much, even though they do still have workforce shortfalls. There's nothing quite as critical as what we get to run out here. The challenge is we're going to have to do it really quickly and do it pretty cleverly, because we can't really afford to break it as we build it. So.
Yeah, so true. And I've often celebrated the fact that we've got yourself as the president of ACRRRM from New South Wales. We've got the National Rural Health Commissioner, who's also in New South Wales. We've got Dr. Nisha Khot, who's in Victoria, and these eastern states are, needing to have some fairly urgent action to change the status quo. The statistic that I like to share that I think really sort of highlights how urgent this is. The born before arrival rate in northern New South Wales is now 1.7%. It's more than double the rate from 2001. It was 0.7. And in rural and remote areas of New South Wales, the figure for born before arrival is now 5%, or 1 in 20. And that to me is staggering, and it really highlights how urgent the need is. Thank you, Dr. Martin. Professor Jenny May, I remember at one conference you and I were sort of chatting about saving the world, and we were talking about the rural birthing index as a really helpful tool in planning for the appropriate levels of service availability that needs to be in each region. I guess the question is around whether this data is available across all jurisdictions of rural Australia. Who should be responsible for overseeing that data, and is there funding to allow for the birthing index to be monitored at a state and national level?
Marian, I think it's a fabulously good question, and I'm going to unpick it a little bit. So all of us know that data can be used by whoever has it to do whatever purpose that it's deemed for. It's the damn statistics and damn statistics. So I first of all want to put a caveat on it, that really what we've heard from Sarah and from Cristina is the narrative, and it's actually the narrative that needs to drive this. This is about equity, this is about fairness, and this is about choice. So sure, we can look at the Rural Birthing Index and we can see if it can provide some of the quantitative data that sits behind an approach to where you put various levels of maternity service. And I can see that Michael has put in the chat a really good point, which is that often the poor outcomes from people not birthing in facilities is regarded as nobody's fault, and therefore it doesn't make it into the qualitative or quantitative statistics. So I do believe that the Rural Birthing Index is a good start, but I don't think on its own it will be enough to turn the tide. So I think that the story, the narrative that certainly I am talking about is maternity services are a choice that rural women should have, and those choices will obviously be more limited than they might be if they were in the middle of a metropolitan area. But if we think about it, and if we think about the relationship of appropriate information that informs choice, if that choice is much more limited, then again, we are talking about responsibility to women who live in rural areas. So I would imagine that the Rural Birthing Index material is there. I'm not sure that it is particularly good at picking up First Nations women. And again, what you're looking for is a quantitative formula that will allow you funding to provide a service in a certain area. As we're going to keep talking about, one of our troubles is not necessarily the funding, it probably is, but not necessarily the challenges is workforce planning, the absolute absence of it. But as well as that, the reason that people don't want a workforce plan is that they don't know where the workforce comes from. And we haven't done a good job in cementing the pipelines that we need to provide the workforce we need. There are no rurally based maternity courses, postgraduate. There are a few master's courses that you can do online and in facilities, but there are no undergraduate midwifery courses that run wholly and solely outside MM1s and MM2s. So our student midwives who go on the undergraduate route are not going to be place-based, or if they are, they're going to have come back to a rural area with little or no undergraduate training in that area. So I think there are some very clear holes in our workforce planning. I'm probably more knowledgeable about the GP obstetric end and the RG training end, but I'm not going to labour the point. I was promised 2 minutes only. But I think if we keep in mind workforce planning is central, but the reason that people mightn't do workforce planning is do we have a tool that's good enough? And secondly, do we have the ways and the support in which to incentivise and get the workforce we need?
Thank you. I wish I could listen to you for a whole hour or longer, Professor. I think, I think I agree. We need to build things so that the pipeline makes sense and people are training where they end up working. It's a good segue to I guess our next theme. Professor Chamberlain, I wanted to ask you, so the rates of stillbirth for maternal mortality and preterm birth are much higher in the far north of Australia compared to those below the Tropic of Capricorn. Women who give birth before arriving at the hospital, we know, account for 0.7%, according to the latest data from New South Wales, but in rural and remote areas, that's much higher. I guess considering what happens around sort of adverse outcomes when, we have preterm birth, small for gestational age, things that do affect our Aboriginal and Torres Strait Islander women disproportionately more often than it does for the rest of the population. I guess, is there research that needs to be more attentive to that situation? Are there possible etiologies, contributing factors to that trend? And what can we do to explore and respond to these trends?
Yeah, thanks, Marian. It's quite a big question. I think, in terms of stillbirths, in the far north and the high rates of that, access to culturally safe continuity of maternity care is, clearly important. And just to agree with the previous speakers about the need for choice and continuity of care being really central to trying to improve those outcomes. There's been quite a lot of research conducted by the Centre of Research Excellence in Stillbirth, so I'm sure the listeners are probably familiar with those packages, but there's a bundle of care for for non-Indigenous women, and there's also the Stronger Bubba Born program that's been put together for Indigenous women. They tend to be individually focused, so they're at an individual kind of clinical level, but there's also the broader healthcare access issues that's likely to be a major cause of the disparities in the north, as well as compounding these risks, the socioeconomic disadvantage and lack of access to culturally safe informed continuity of maternity care. So we really need a bigger investment in that, and that includes models such as birthing in our community that we saw in Brisbane, where we have real active engagement of community controlled services in helping women to ensure access to maternity care. I guess just to reiterate what people say about, there's also all the logistical issues that people have, you're living in remote areas. I did used to work with the Flying Doctor Service. We're all familiar with how the logistical issues can make it really hard to access services. So I agree with everyone about keeping rural and remote services open and as close to home as possible is clearly important. And I know there's a lot of strategies to support women who live further away to stay close by in the last few weeks of pregnancy, but that is pretty variable. It's hugely inconvenient for families. It's virtually impossible for some parents to actually do that with their other caring responsibilities and things going on in their lives. And, some women, particularly, I know our Aboriginal and Torres Strait Islander communities, that women don't feel safe in many of these facilities. And so I think it's really important that women who live, more than the 30 minutes or so from healthcare access, do recognise the early signs of labour, advised to come in as soon as they can. I'm sure people are doing that, and really there's a focus on making people welcome when they do arrive, and not sending them home or anything like that. If if they don't if they're not in active labour like people would do in the city. I'm assuming people don't do that in rural areas, but they're just sort of practical things. And I was also just I don't know if it helps to have for women to have emergency kits just in case. I mean, they're all really, really poor. You shouldn't need that. But just thinking about some of those kind of things, but also, practical things like making sure there's a car available when needed, that, people have got petrol in it, and some people might take that for granted, but certainly, for a lot of people in our communities, we certainly can't take that for granted. And I think, in the end, all we can do is really offer a range of options, make them as culturally safe as possible, follow the evidence about culturally safe continuity of care, and respect women's choices about what they need to do.
Yeah, absolutely. And what powerful things to continue to put to the surface of our priorities as a nation. Working in the Kimberley, I know that this is the largest retrieval zone in the world. Like, we are dealing with massive distances and having to displace so many women to be going through something that is as life-changing as birthing and bringing new life into the world. It is a major issue. What we're asking them to do is too much, and it's no wonder the statistics are what they are. A really good segue. Thank you so much, Professor Chamberlain. I think, again, another good segue to Dr. John Hall and what he's been able to achieve in WEPA. Dr. Hall, I'm sure you've been asked this many times, but I think it's important for the audience here tonight again. What does it take to reopen a rural birthing facility in terms of advocacy time, resources and staffing?
Thanks, Marian. And it's great to be here, and it's great to be talking solutions. The advocacy to get WEPA reopened started in the early 2000s. So this is a long game. And there is many of my colleagues who've been working tirelessly on this over the years, and particularly calling out RDAA and the RDAs across the country, the state organisations who've been, I think, some of the loudest voices when it comes to advocacy. And it's been that sustained long-term advocacy. I think part of what sets us aside from other medical organisations is our ability to collaborate with with the midwives, with the community organisations as well, and stand shoulder to shoulder for the communities and having a community focus. I think, you've got to understand why these birthing services were closed over time. And a lot of this came from a misconception, a lay misconception amongst politicians and bureaucrats that you couldn't deliver a specialty service like obstetrics in remote locations or rural locations and for it to be safe. One of the things that we've been able to consistently show is that and often these organisations like governments and health services talk about risk in terms of their own risk. It sort of goes to what Michael was saying about if I don't organise an elective service in my patch, then it's not my fault if something goes wrong. But we've been able to consistently show that the perinatal mortality rates are significantly higher in places where we aren't birthing. And that's, in North Queensland and remote areas, it's 23 in 1,000 and rising. So, I think showing the government, showing health services and state governments that run secondary care that if you're trying to use the argument of safety, it's flawed. You're wrong. You've got it in reverse. So I think that was key. And as part of that, it can't just be an opinion based. There's been lots of data that we've used to back up those arguments as well. Along the lines of those born before arrival statistics that you showed and the perinatal mortality and morbidity. One of the other key things I think that has helped our argument is when you look at the pooled data in places where we are doing elective birthing rurally, our perinatal outcomes, our other indicators for outcomes are exemplary, and in most cases better than the state and national averages. So I think that contrasting data hit home for a lot of politicians that I've spoken to. And I think that was sort of some of the important key points of the advocacy that I think has shifted opinion over time. And then once we turned the tide, particularly in Queensland with Bow Desert, it changed the attitude, it changed the narrative. And I think that's become a bit of a national snowball where that opinion that it's not safe to do this, and in fact, it's safer to provide services, I think has spread around Australia and is growing. So I think that's really exciting. From the prospect of time, it takes a long time to change public opinion and lay opinion and government opinion, as you've heard. In terms of the microcosm of a single unit, you need to have the infrastructure that is fit for purpose. You need to have the political will. You need the will of the health service that you're in. And you need, the right resources on the ground. Staffing wise, you need enough GP obstetricians, GP anaesthetists and midwives to run safe and effective rosters. And we were required to deliver those rosters before we were permitted to start in our patch. So I think when it comes to the advocacy side of it and the outcomes as well, the concept, getting people to understand that no government, no politician, no health bureaucrat decides when and where a woman will have a baby. The majority of the poor outcomes that have happened around increasing perinatal mortality in First Nations and remote communities is around imminent preterm birth. So that there it also behoves us to make sure that in our communities where it's not possible or they're not of the size that could maintain a fully staffed birthing service, that our imminent birth preparedness is there and effective. And I spent some time in 23 in the London School of Hygiene and Tropical Medicine doing a research proposal around this. And one of the things that really struck me in the face was I think Africa does imminent birth better than Australia, than rural Australia. We tend to remove everything obstetric related away from communities where there's no midwives and doctors because there's not the skilled staff to use the equipment and the drugs, whereas Africa has got a very evolved system for managing emergency obstetric care, and in some cases I think better than us. So there are 2 points, sort of take homes, and I know I've gone for more than 2 minutes. This is always going to be hard for me. Redefining, I think the key thing is redefining risk, and we need to talk about the risk to the community and the risk to the women and their families, not the risk to the organisations, not medico-legal risk, not political risk. And we need to remove that as political and bureaucratic barriers. And then the second take home is not letting perfection get in the way of the good. When I talked about resources and staffing, I think too often we want the perfect roster, we want the perfect number of midwives, and we don't feel comfortable starting a service if we feel that if it's not going to function or it's going to be vulnerable. But one of the key things that happened with us is we kept saying to our colleagues, if you build it, they will come. And we had to sort of prosecute the argument that we can't wait for it to be perfect to open the doors. And this came to pass. We recruited more midwives after we'd opened. We were running on a mix of permanent and agency midwives, and the same with doctors. And when we opened the doors, more people came. And I think midwives and doctors don't want to work in maternity units that aren't birthing. In fact, Weeper had been trying to reopen for about 3 years prior to I got there, and they'd already lost staff who'd come to be part of the birthing who left because the birthing didn't happen and they wanted to do intrapartum care. So I'll leave it there. Thanks, Marian.
Yeah, I wish we could continue. I think a lot of those themes are so important. The other thing I was going to say, issues like making sure we have the infrastructure for national credentialing, this issue of, I can't work cross-border because there are 1,000 forms and multiple hours, multiple people that need to be convinced that I can be credentialed in more than one place at once, is huge. And it's something I know RDAA is working on. But that infrastructure to allow us to mobilise our workforce is so important. And to recognise that, as a few people have said in the audience, birthing doesn't need to happen with someone who, is, a specialist who does only birthing and nothing else. We actually need a workforce that has diverse skills who are able to, provide good services for the community. And it's something that, we use to design what is available. So thank you, John. That's amazing. I'm going to take a bit of a pivot because I'm looking at the clock, and I think this is another important theme we need to address. There's an undeniable change in the face of obstetric care at the moment. Consumers are calling us to a higher standard, to decline standard care, to allow women and birthing people to feel empowered and in control of their birthing experience. I attended the birth trauma course that was run by RANZCOG this morning, actually, and I want to congratulate RANZCOG for teaming with Birth Trauma Australia and for having that education. I think it's so important. And rurally, in some ways, we have the advantage of having smaller teams where we are able to provide that continuity and to ensure that women and birthing people feel safe where they birth because they have familiar faces that are there. I might ask Dr. Nisha Khot, is there some advantage that you see or some things that you see rurally that make us almost in a way safer in terms of the risk of birth trauma?
Thanks, Marian, for having me. You have just listed the exact things that make you so much better at prevention and management of birth trauma. The fact that it is a smaller team, the fact that, as Judith, who is on here, has always said, that this is true continuity where you see the same person through all of your prenatal, perhaps even as a child, and you grow up with the same GP who then looks after you through your pregnancy and looks after you after you have had a baby, is the true kind of definition of continuity, if you like. And so you definitely have the advantage over the big metropolitan kind of juggernauts, if you like, where thousands of babies are born and there is very little continuity unless you are lucky enough to be in a midwifery publicly provided continuity of care program. I think it's really important that we do recognize the reality of birth trauma. I think, we have for far too long kind of put it aside, if you like. And I'm very glad you went to the webinar this morning, and I'm very happy that we are providing some education around birth trauma, how to recognize it, how to manage it. One of the things that I'm sure you as rural clinicians are seeing, we as metropolitan clinicians are seeing, is the rise in, like you said, women who decline standard care, and also women who choose to free birth or home birth in situations where it might not be advisable. And I think the best way to manage that is to try our best to reach out to these women. I completely acknowledge that that is difficult. Someone who wants to free birth is not going to come and see us. That's the whole point, that they don't want us. They don't want the doctors. They don't want the midwives. But if we can change that narrative and make our birthing services a welcoming environment, what I hear often is that privately practicing midwives or women who are free birthing feel like when they do come to hospital, they're judged. And so that makes them even more reluctant to come into hospital. And so I think if we can create that atmosphere, that culture where we say, you know what, no matter what choice you make, we are here to look after you and we are here to care for you. And if you come in, you will get the care that is the best care that we can provide. That will hopefully change that narrative and make our maternity units more welcoming places. And that is the basis for kind of trying our best to do things slightly differently. I think for far too long, and I think again, rural maternity units do it better. It's in metropolitan maternity units often that the midwifery versus obstetric narrative can happen. Whereas I think in most rural units, it is a midwifery and obstetric or a midwifery and medical model where there is much more collegiality, because after all, we are dependent on each other as professions. We are a team, and unless we work together as a team, we are not going to achieve the best outcomes possible. So again, I am very much in favor of metropolitan and tertiary units learning from the smaller rural regional units. We have again this whole culture of, oh, we are in the ivory tower and the little rural units must learn from us. Actually, the reverse learning is much more useful as well. So I will leave it there and say that, rural maternity units do a great job. They have much more collegiality than I see in perhaps the bigger units. And there should be a two-way learning. We should learn from rural units. Metropolitan units should obviously also provide teaching and learning for rural units.
Well said, Nisha. And I've kind of joked before that I'd love to clone yourself, Dr. Jared Watts, Dr. Marian Clark, some amazing RANZCOGs across Australia, because in many ways, the way that we have that mutual respect between our different roles, midwives, GP obstetricians, ONG consultants, I feel like that flattening of the hierarchy and working together, I've named this webinar Stronger Together because we absolutely need to consolidate that, that flattening of the hierarchy and working together. It's so, so important to providing really good team-led care. So I guess to the theme that I wanted to touch on, and I think Vid mentioned this in the chat, the term obstetric violence has created a bit of a rift between, some of us clinicians as well as some of our consumers, our very important consumers. And we've often talked about, clinicians who go into women's care are usually so passionate about providing excellent care. We're not trying to create harm. We're actually trying to help. And the reason that we use women's care or choose to go into women's care is because it's something that we want to support. I want to ask Sarah, as a consumer, as well as Cristina as well, if you wanted, what do you feel can be helpful in breaking down that division between consumers and clinicians?
Well, for me personally, I think just acknowledging that the term obstetric violence is quite abrasive amongst doctors and midwives, and I think it's a really important conversation to open up between yourselves and consumers. And I feel really fortunate that this hasn't been my experience, and I genuinely do believe that the vast majority of doctors and midwives are utterly incredible practitioners, and they work with the woman for the best possible outcomes. But it's also crucial to acknowledge that for some women, this is not their experience, hence why we are having to have these conversations around obstetric violence and birth trauma. And what I think would really bridge the divide is just remembering that we often are talking about the same thing, but just in different languages. So clinicians might hear the word violence and understandably you feel judged or blamed for actions or inactions, but consumers or women are using it to describe their experience, their reality, and potentially not necessarily a judgment of the clinician's intent. I think that when we are dealing with patients who have experienced birth trauma or who are saying they've experienced obstetric violence, that we need to create safe spaces where they can share that experience without feeling like they're being targeted or judged for bringing it up, and acknowledging the impact that this has had on this person's birthing experience, regardless if the intent was good or not. And most importantly is just clear, respectful communication during that care. So constantly asking for consent, saying to the person who's giving birth, here is what I need to do, here's why I need to do it, and here are your options. And I think in rural settings where resources are stretched and there are fewer choices, this becomes so much more important, I guess. So just working together between the women and the clinicians from pregnancy through to birth and postpartum care, I think is the most valuable and important thing that we can be doing.
So well said, Sarah. Thank you. Cristina, is there anything that you wanted to add?
I think Sarah said that pretty well, but I think it is important to acknowledge that trauma is the experience, not the event necessarily. And as health professionals, we're quite immune to a lot of the invasive procedures that are just standardized for us. But what I have noticed is rural health services and small teams do consent really well. A lot of this is about proper informed consent and education in pregnancy, so women and their families know what could come up, what to expect, and what their options are. And health professionals need to respect the choices and decisions that women and their families make.
Absolutely. And I think, as a clinician, I've learned through my career as well, always remember that consent, even if it's given at the beginning of the procedure, it doesn't mean that you can continue. Make sure that you're continuing to check in with the person, making sure that they're still, they're not withholding their consent or withdrawing their consent at any point. And always provide options, even in an emergency situation. If there often is more than one option, and it could be that the woman wants to prioritize her pelvic floor or wants to prioritize the baby's well-being, and it might not be the priority that we have as clinicians, but offer the options and let them know what the outcomes may be either way, and empower the woman to be able to make those decisions. It's so important.
Right.
Thank you.
Continuity of care, that's when you get that women are more confident to express their feelings and speak up for themselves as well, and the clinicians know them better and can tell when they're uncomfortable, or they know in advance what their wishes would be.
That's so true. That's so true. And that's our advantage as rural hospitals and rural teams. I think that we absolutely do have a better standing point, or a better starting point, because we know our patients well, and we're able to give them that open door to come and talk whenever they want to, and to know that we've got their best the best intents and the best intentions for them. This is probably a question to Nisha. We might, I know that we're running out of time, and please feel free to leave if you need to. Nisha, there are, I guess, concerns around GP obstetricians being able to complete their logbook, and we're worried that the pipeline that we're hoping for is not coming. One of the things that I know RANZCOG has had a standpoint around whether they are able to, get involved in workforce issues where perhaps there is a health service that isn't being sort of as collaborative as they can be with between GP obstetricians and O&G consultants and midwives as well. What things can we do from a training perspective? Is there a way to incorporate things into training that allow our amazing O&G consultants to understand the role and the capabilities of our midwives as well as our GP obstetricians, particularly in rural settings, so that we can collaborate better and have that mutual respect?
I think, Marian, first of all, it's really important to acknowledge that a proportion of people who train in the sort of things that the college offers are actually doing that training with a view to becoming specialist obstetrician gynecologists, not with a view to becoming GP obstetricians. So I think that is one thing that we have to acknowledge. And how do we make that difference between people who are doing all of that training with a view to using it to become a RANZCOG versus using it to become a GP obstetrician? That's one thing. The second thing is that the college is working on including accreditation. So we as a college have accredited training sites with a view of RANZCOG training, but we are working very hard to incorporate some GP obstetric training as part of that accreditation process, so that then we can hold those training sites accountable for the training that they are providing for specialist obstetricians as well as for GP obstetricians, whereas we've not really had that mechanism of holding training sites accountable. That's the second thing. The third thing that I want to say is actually once you become a GP obstetrician, or if you are a rural midwife, one of the things that keeps you in that role is having ongoing training and education. And OGET, which is the college's program of obstetrics and gynae training, is a sort of hub and spoke, which doesn't involve tertiary organizations. I think that is the key to it, to have a regional hospital that then provides that training to its local rural hospitals that refer to it. So that helps then with ongoing training. So we recognize that it isn't just the training that you have before you become a GP obstetrician, but the ongoing training that you need as a team, not just as an obstetrician, but also as a midwife, as perhaps the emergency physician, as the anesthetist who attends the cesarean section, as a team. And so those are the few things that the college has currently, either in the pipeline or already in practice to keep that rural obstetric maternity workforce going.
And I echo what's being said in the chat. That's very well said, Nisha. Thank you. I think it's, the OGET project is so fantastic. I'm wondering if we can take it a step further and talk about skills maintenance. GP obstetricians working in rural areas, we know that our regional and our metropolitan units have an obligation to train their own trainees, and I very much acknowledge that. I know that that's a priority for them, but having protected time or lists for our rural clinicians to be able to maintain their skills so that they can continue to deliver care, it takes pressure off our metropolitan and regional centres and allows that that face-to-face relationship to build between our rural clinicians and our metropolitan and regional centres. Is RANZCOG in a position to be able to support that, where we can build a list of hospitals or clinicians who are happy to supervise or happy to allow that skills maintenance to happen? Is that something that RANZCOG may be prepared to think about?
Marian, certainly, I think part of it has to do with individual hospitals and healthcare providers. So the college has a role, but there is a role for the state and territory providers of healthcare to actually also facilitate that. Because no matter what the college says, ultimately, the facilities and the cooperation and the actual, how it works has to come from the local hospitals. And so absolutely, we have always, advocated for it, and we continue to advocate for it, but we need other people to come to the table as well.
Yeah, absolutely. This is multi-person, and it's organization that needs to work together and collaborate. And I absolutely agree with you. Jenny May, I'm sorry about the time over that we've gone, but I do want to ask you, I think, with the dropping number of obstetric trainees and applicants across rural Australia, that's both in O&G consultant specialist training as well as rural GP obstetrics. We are really keen to work with the Ministry of Health to create that pipeline and to support and mentor people, not just with money, but I think with being able to mentor people and allow that supervision to continue. I know that in my journey, I struggled with transitioning from being in a regional centre with, the paediatric team and NICU and all of that around to a rural centre where suddenly I'm the one who's looking after the baby after they're born, and I'm, having to do cesareans independently and that sort of thing. Is there opportunity for us to formalise some sort of a mentoring program that allows us to have, lifelong supervision with mentors? Is that something that we can possibly work on together?
I'm sure, and I'm sure that, from where I'm sitting, doing nothing is not an option. So it's very clear, having identified that there is this gap and there is not workforce planning going on, and identifying that we've got multiple players in this picture. We really are going to have to eke out a plan that goes with a pipeline approach like you're talking. Transition to practice is now often talked about, not only by GPOs, but also by midwives, about how they feel about professional practice without appropriate support. So we train people in certain places. We expect them to work in different places. We need to have a really good think about this step up, step down, transition to practice, where you get volume, where you get skills, and where you get context that really meets the need for the sorts of practice that you will be undertaking. I can only echo the need for the professional support as a lifelong issue. Maternity is the only place where you must operate as a team. You do not have a choice. You can be a bad team, by all means, but, so how come we don't prioritise and understand that respectful, collegiate, supportive approach that we must have if we are going to provide women with the best possible care? So yes and yes, but obviously I don't represent the government. I am independent, which is my good fortune. But does it mean that I'm not absolutely committed to a training and thinking approach that is the whole span from training through to culture and practice? I am. And am I thinking about multidisciplinary? Yes, I am. That is absolutely imperative. GP obstetrics must be supported because we have 80 level 3 facilities in Australia, and we need for rural women to have some choice other than level 2 to level 4, let's be honest, is not a reasonable choice for women to make. So we have to act, but we have to do it bringing the states with us and making people accountable for all the pieces in the puzzle. Sorry, I was over 2 minutes.
No, that was perfect. Thank you so much. So yeah, it's 10 minutes past 9 o'clock, I think. It's 10 minutes past 6 where I am. I just wanted to say a huge thank you to all of our panelists and all of you who have attended. It's so important to continue to have these conversations and to understand that this isn't an issue that's going to go away. It's multifactorial, it's very complex. But as I titled the webinar, we are much stronger together, and I'm just one voice, but I so appreciate everyone who's gone along this journey with me. I want to acknowledge all of the people who are on the board for the Australian Rural Maternity Association, a very diverse group, a very amazing, passionate group as well. So our website for anyone who is looking for it is ruralmaternity.com. If you feel the tendency to support us, please join. We have a mailing list that doesn't cost you anything, so please join us. I have lots of projects that I have in mind, and I would love to have as much help as possible. I know that we have lots of skills that we can bring together to create something much bigger than ourselves. Thank you for attending, and thank you again to our panelists. It's been a really great conversation, and I look forward to continuing it.